Okay, why don't we go ahead and get started? Today's another one of our 3-for-1 deals, so you can have 3 pieces of pizza. Today's another one of our summer intern presentations, so hearing what our summer interns did on their summer vacation. So our first speaker is Anna Stănescu, who's going to talk about work that she did, I assume, with Joan.
Yeah, can everybody hear me okay? Okay. I'm Anna Stănescu. I've been working on the Oral History of Medical Informatics project, and Joan is my official mentor, but I've also been working really closely with Michael Shapiro, who's also part of DMICE, and Dean Sittig from the University of Texas. And of course, my summer work is funded by the National Library of Medicine grant. Dean and Joan started this project in 2004, way back in 2004, and over a period of 2 years, they conducted 13 interviews with pioneers of the medical informatics field, and a 14th interview was done just last winter. So just to give you some idea of who I mean when I say pioneers of medical informatics, I put together sort of a yearbook page of the interviewees. So for example, you might know that Robert Ledley, who's in the middle of the first row, invented the first computerized tomography system, or CAT scan, that could take images of all different parts of the body. And for the first ever CT scanner that he made, he actually drew the designs and then went around to a whole bunch of different people in town to get the different parts created. So a machine shop to make the parts, and then I think he went to Capital Cadillac to get the thing painted. So it was a very homegrown kind of effort. Morris Collin at the bottom left developed an automated Kaiser Permanente's multiphasic health screening, and he also created one of the first computerized patient records. And of course, he had the most prestigious AMIA award named after him. He's actually still around and attending AMIA meetings now, even though he's, I think, 97, and he's still working and active, which is really impressive. Reed Gardner, in the middle of the second row, was an innovator in biomedical instrumentation, and in his efforts to computerize spirometry, which is measuring breathing, he actually created standards for the accuracy of existing spirometers and a testing device to test that accuracy. And of course, we have Don Lindberg on the far right of the second row, who is the current and has been the president of the National Library of Medicine since 1984. And he was instrumental in shifting the NLM's focus to a medical informatics direction. So Joan and Dean sat down with each of these people for a couple hours, and they recorded their stories about where they grew up, what they thought their most important accomplishments in their career were, what their disappointments were, and how they got involved in the medical informatics, then new medical informatics field. And there's actually a lot of debate about what constitutes real history and what the value of oral histories are. But the way I see it, oral history is kind of like in this picture, which I hope you can see clearly. It's kind of like being a kid and sitting around the camp or sitting around the fire in the evening, listening to your grandparents tell stories. So you're not listening to them because they have the most authoritative say on the topic, but because they're your family and they were there living through these events, and they have a very unique perspective on the topic. So in a way, I kind of feel like we're all children when it comes to this stuff. We know about systems like MUMPS and CoStar, but we weren't there in witnesses to the process of them being created. So we have a sense of them the way they are now in their existent form, but not of what it was like for that process to be happening. So I think oral history can give us a glimpse into how these people's lives and interests and personalities might have shaped those innovations that we're more or less familiar with. And I think oral history is best looked at as a collection. So instead of having a single story with all the facts, you can compare and contrast different accounts of the same event or development. And you can ask really interesting questions like, why do these two people have very different ideas about a a certain subject, whereas these other two people over here have a very similar perspective. And I'm going to come back to that later in the presentation. So I think to that extent, the more oral histories we can incorporate into this collection, the better. And we're actually really excited about the fact that the American College of Medical Informatics has set up a history committee, and they're actually going to be having a meeting in October to discuss extending the project and doing more oral histories. So we're really keeping our fingers crossed that that's going to happen. So Joan and Dean's intention was to do at least a dozen more interviews and for the audio tapes and transcripts to be archived with the National Library of Medicine and the transcripts actually to be made electronically available to people in medical informatics and related fields. But once the interviews were transcribed, not everybody was exceedingly happy with the way that they sounded in the interviews. So that's where my part comes in. I've been spending this summer collaborating with the interviewees on editing their transcripts so as to get them into a form that they're comfortable with publishing, but also not letting them modify the original feel and content of that conversation too much and letting them take out all the juiciest stuff. So it's definitely a lesson in sort of picking your battles and deciding what's most important to keep and what isn't necessarily worth debating with them about. And actually, the title of my presentation is a representative example. The title was the very last line of an interview that we did, and it originally said, "I cannot ever recall failing to take pleasure in reminiscing." But later in the editing process, for the sake of clarity, the interviewee modified it to say, "I never fail to take pleasure in reminiscing." So while I think the original is a little more cumbersome, I think it's also more evocative because it has both the word recall and reminisce, and it's sort of, they both have to do with memory. But this wasn't one of the changes I chose to dispute because there were other more important sections to sort of quibble over. And it was also interesting to see the way different people's personalities came through in the editing process, even though we were only interacting through email. So we were sending documents to each other back and forth, tracking our changes and making margin comments. But everybody had different approaches. So some people contacted me with very specific questions about what they were and weren't allowed to change, and they wanted to know, should they just clarify certain parts, or should they also modify the grammar and add in more information? Whereas other participants basically said, sure, I'll work on it, and they never told me about any of the issues that they had with parts of the transcript, but then I got it back and it was all red because they had deleted and rewritten entire paragraphs. So to talk about some of the content, I wanted to bring us back to the idea of comparing and contrasting different perspectives and use the formation of AMIA, or the American Medical Informatics Association, as an example. So we know from Maury Collins' A History of Medical Informatics that AMIA was incorporated in 1989 from 3 pre-existing organizations. ACME, which stands for American College of Medical Informatics, SCAMC, which was the Symposium for Computer Applications in Medical Care, and AMSI, which was the American Association of Medical Systems and Informatics. Which is kind of a lot to take in. But after 2 years of meetings between the officers of the 3 different groups, Colin, in his book, his history, tells us that it became obvious to all involved that there was considerable overlapping between the memberships of the governing bodies of these 3 organizations and that they would all benefit from a merger. And then he goes on to talk about the conditions under which these 3 organizations became subsumed under AMIA. But I feel like we don't really get a sense of the process of negotiation and what that was like. So looking at the transcripts, we can see that the people involved didn't all necessarily have the same perspective on the process, and that they had different understandings of the value of the 3 preceding organizations and the necessity of even constituting AMIA. So I wanted to provide sort of 2 alternating ideas about SCAMC. For Reed Gardner, SCAMC's meetings were a very important place to get acquainted with professional colleagues from all over the country and, in fact, all over the world. And he saw SCAMC's meeting as a great place to get feedback on research and criticism and interact with people. But another one of the interviewees, who I can't actually name because I don't have his permission yet, we're still in the process of editing, said that from his point of view, SCAMC wasn't a good organization at all, and it had really trivial meetings that were caught up in all these monetary issues. And in fact, in a different interview, SCAMC is described by one participant as very resistant to the process of incorporation into AMIA because they were afraid of losing their membership structure that had allowed them to make a lot of money without spending very much. So all this isn't to say that there's that one of these people is more right than the other, but just that kind of like in the painting, the MC Escher painting, it's all really relative and it depends on the different positions of the people involved. So to address the actual negotiation process, it definitely wasn't sort of a unanimous decision or an easy thing to do. There were 15 representatives from the different companies that got together to vote on this stuff, and one of them describes the process as difficult, bloody, and there were compromises almost like in Congress. And there were actually some individuals who were really, really seriously opposed to the idea. And one of the interviewees says that one very senior guy in the group stood up and essentially said, "I'll never speak to you guys again in my life," and walked out, and that was it. And there's also an account of a different person who was so upset over the merger idea that he threatened to sue everybody, claiming that there must be something illegal about everything that they were doing. So it just goes all to show that the decision to form AMIA wasn't, like I was saying before, a unanimous sort of idea, and we can't really take the existence of the organization as a given without interrogating that process that went into its creation. So to move to a more positive note, I wanted to pull out some of the overarching themes from the transcripts that are also pertinent to the audience. And one of those was that of collaboration and community. A lot of the interviews talked about the kinds of relationships that they formed with the people in the field and how bright and interesting their colleagues were, how their colleagues were their friends, and how they're very, very excited to be teachers and mentors to the next generation and to witness those people's accomplishments. And one interviewee, when he was asked about his proudest moments, actually insisted on saying that a lot of the things that happened are because of very, very good people working together. And there's also this great quote, "Certainly the most fun has been working with these people. I really do enjoy the field and the people in it. The type of fellowships and friendships and tennis games we've had over the years are tremendous. I don't know how many other fields that have had this type of camaraderie on the national scale." And you might feel like there's kind of a contradiction between the two slides I just showed you and the stuff we were talking about before, because these ones are all warm and fuzzy, and then we have the stuff with the conflict. And you might be going sort of like, which is it? But I think part of my point and that of oral history is that events and people have this capacity for multiplicity and different points of view. So one person or one event, there isn't a single story about them. Another one of the themes that was really pervasive throughout the transcripts was that of taking risks and not necessarily having a set career path, but following your interests and seeing where that takes you and trusting that that's the right place for you to go. And believe it or not, actually, several of the interviewees used the word serendipity to refer to that, so I just couldn't resist having the movie poster up there. So a good example of that is Don Detmer's strategy, which was to begin doing what you think you'll want to do next, and then somebody will call you to do it. And he also talked about jobs just falling into his lap, which I think is does not necessarily apply to all of us and is pretty exceptional. But I do think there's something to take away about following your inspiration in life as well as in your career, and believing that that's going to take you someplace that you want to go. So I wanted to leave off with a very humorous and inspiring quote from Nina Matheson, who said, "I especially think if I had paid more attention to the objections of people, these things wouldn't have happened or they wouldn't have come about. But being somewhat closed-minded, you just go ahead and do things." I don't think one should be closed-minded. I was sort of joking. But I think you really need to persevere if you have a vision and stick with it. And if you're interested, these are the sources I used for my images. Questions?
Thank you. That's an interesting presentation. It does raise a question, though, since you're going through and running through revisions, is what kind of revisions you would accept? You clean up the grammar? Would you accept a deletion of a statement or a revision of a statement? And how did you decide what you accepted?
Some people, so mostly people like to delete their ums and ands and so's, so very sort of small details that were part of the flow of conversation, but they think don't look good on paper. And then there were parts where people wanted to delete maybe entire pages, and we talked about their reasons for doing so, and sometimes it would be things like, I don't think this very accurately reflects my opinion, and it would take an extra 2 pages to actually really get into the meat of it, and so I felt like it was fair enough that they didn't want to include whatever those statements were, because they didn't want to misrepresent themselves. Let me think of other kinds. There were also places where people rewrote statements that were more technical and relating to sort of really technical things to clarify exactly what was going on, and I thought that was really useful. So I think, yeah.
Thank you. Are the techniques for finding themes in oral history similar to that of other types of qualitative research, or are there kind of unique aspects of coding this type of data?
Well, I wouldn't actually say that I was going through and coding it, but I mean, yeah, sort of with a highlighter and identifying, similarities. I haven't actually done that much other I haven't done coding in a qualitative research context, so I'm not sure what the similarities are.
I'm just amazed that parking would be an issue. It's never an issue around here or anything. This is very interesting. I'd actually be curious to put you on the spot a little bit,
Okay.
perhaps. So you've read through oral history of some of the luminaries in the field, and I'm wondering if you have any kind of big takeaway points about the informatics field to share with, well, certainly with your fellow interns, but actually with some of us who might be interested to kind of see what your big picture perspective is.
Well, I think the parts at the end of the presentation were definitely the takeaway messages that they wanted to share, because there was actually a question about what advice would you give to future informaticians. So there's very much excitement about the field and feeling like there was so much more to do, and several of them actually mentioned they wish they were 40 years younger so they could get involved and do all these different things, because there's a lot of work still. So I think it's definitely this sort of inspirational excitement going, and the excitement about working with really great people and really intelligent people.
If I could just follow up, but what about the kind of the themes of what the field does? I mean, what is your perspective in reading these transcripts of these luminaries in terms of what we don't commonly as much anymore call medical informatics, but what
Already outdated.
Yeah, what the kind of big themes, areas of focus of the field are?
Well, a lot of them talked about really noticing, because they mostly started out as physicians, and noticing the errors that people made and the ways that they felt things could be improved very greatly by using technology, by provider order entry or computerized patient records. So I think a lot of it is, I guess, efficiency and they had issues with how they felt like things weren't going as well as they could be, and they continue to sort of think that there's improvements to be made. More questions?
Okay, good. Why don't we go on to the next speaker? Yes. I don't know who's. Oh, here we go. Okay. It's actually interesting that a fair number of those people on that screen, who are some of the oldest people in the field, are actually still working. There's a lot of newer fields, not true fields like math or physics that, some of the people worked centuries ago. I also just wonder about 20, 30, 40 years from now, whether some of us will be up on screens like that. But anyways, not for a while. That's right. Good. So our next presentation is by Katrina Birch, who is going to talk about AYA, Fertility Preservation Explorer, user testing and data management, and worked with Dr. Eden and Dr. Block.
Try not to knock this cord too much. So like I said, I'm Katrina Birch, and I've been working with Dr. Karen Eden with DMICE and Dr. Rebecca Block with the Knight Cancer Research Institute on the Adolescent and Young Adult Fertility Preservation Explorer project. And my primary activities have kind of revolved around user testing, various aspects of it, as well as data management. So just an overview of what I'll be talking about. I'll be talking about medical decision aids, what they are and why they're important to healthcare. The AYA Fertility Preservation Explorer project, what it is and why it's important to the realm of research, and user testing and data management. So medical decision aids. They're used to assist people in making healthcare decisions. So and they're different from your basic healthcare education materials like pamphlets or flyers in that they provide more detailed and specific information with an emphasis on options and outcomes in order to prepare patients to make explicit and individualized choices. And yes, that quote is taken from an article. I can't name it off the top of my head, but it's in the back of my presentation, Rates 2008. So in this way, medical decision aids help support shared decision-making, which has kind of become the gold standard in healthcare. And it just helps to give people a sense of empowerment and reduce decisional conflict. And then it should be noted that as of 2008, there were about 500 plus medical decision aids that were developed and tested. And that number has just increased over the past couple of years. So the Adolescent and Young Adult Fertility Explorer is not a decision aid in the traditional sense. It is used to help adolescents and young adult women with cancer learn about and explore their fertility preservation options, and hopefully in a fun way, and informative, interactive way. So, in the process of using the Explorer, they also learn about their decision-making skills and experiences, and it helps them to really explore the tools that they already have in their arsenal to make decisions, or the tools that they desire to make decisions, because research has shown that adolescent and young adult women, as compared to older women with cancer, usually their decision-making style is more rash and emotional, and they're also more susceptible to peer influence. So the tool really helps them just to explore their options and really explore themselves and their qualities that they already possess. So I'll go through some screenshots of the tool with you. This is the What's Inside the Fertility Preservation Explorer screen. It's under the Introduction menu heading. And it's just a preview of what to expect in the Explorer. And then at the bottom, watch out for tips on the right-hand side of the screen. And just throughout the Explorer, tips will come up on the right-hand side. And there's just extra information or helpful links for women going through the Explorer. So here is a screenshot of the first of 3 identical pop-up questions, and these are meant to gauge where the women are throughout the tool with their fertility preservation perspectives, whether something they're interested in, something they're not interested in, and it happens here in the very beginning. It also happens later on towards the middle after they've been looking at information regarding fertility preservation options like ovarian suppression or after treatment options such as surrogacy or adoption. And this is kind of where it starts getting really fun for survivors and providers as well. This is the Who You Are page, and it's asking you to choose 3 words that best describe you. So to really hone in on what you think best describes you. And this is, kind of the starting of where it really gets interactive. And then this I thought I'd show because it's kind of the page that a lot of people have had the most problems with. So what's happened previously is it's asked you to choose who's in your network, who's your support system, your mother, your father, different family members, oncologists. And then it has asked you previously what you want those people to give, or ideally what those people give. And then it's asking you to match them up so you can see, mother, someone to advise or guide me, or the oncologist, someone to give me information. So it helps people to really look at what they already have in their decision-making processes. So, and this is your custom deck. And what this is doing is it's just summarizing everything and just putting it all together so that you can see it all at once. So decision-making skills is the page I had it up on. And then I think ideally what is going to happen is that you'll be able to click on the card and it will show you something about your decision-making style, like you like to make informed decisions, you like pros and cons lists, or your decision-making style is more kind of a fly by the seat of your pants type of thing. So getting to the actual project, it's broken up into 2 phases. And right now we're in phase 1, which is 3 rounds of user testing. We've currently completed round 2 of user testing, and round 3 is going to happen somewhere around mid-September. Phase 2 will include a randomized controlled trial. And the user testing, it involves observations, cognitive interviews, and the administration of 3 instruments. The providers receive both a pre- and post-test knowledge quiz, as well as the practitioner opinion survey for providers. And the survivors also receive the pre- and post-test knowledge quiz, as well as the acceptability scale for survivors. So this leads to 2 types of data, the quantitative, of course, the instruments, and the qualitative, which is primarily what's going on in the interviews, comments, thoughts, likes, dislikes, where they're clicking, etc. And the quantitative data has been managed through REDCap, which is developed and maintained by Vanderbilt University. And OHSU is part of the consortium of 68 universities that spans 5 continents. So the main benefit of REDCap has been that it's easy and quick to build your databases, as well as it can be accessed from anywhere because it is backed up online. All you need is access to a computer. You can log in, build your database, enter data, whatever. And it's easy to export to statistical packages. It saves your variables and all of your data into a data dictionary that can be uploaded to SPSS or Stata to perform more complicated statistical manipulations if that's what you need it to do. So here is the REDCap opening screen. And from here you can manage your project. You can allow or disallow user rights. You can build your instruments. And this is one of the instruments that I built, the knowledge quiz. And it just basically consists of choosing a field option. I've chosen radio buttons, assigning values, or taking the pre-assigned values. REDCap will pre-assign values. It will also pre-assign variable names. However, they get kind of wonky. So I've chosen to just name my own variables. And then it also allows you to enter in Excel-type calculations. The main disadvantage with this has been that they have to be hand-typed, so it leaves a lot of room for error. So if your equation isn't working, you have an error in your equation, and then it's trying to kind of go through and figure out where that error lies. So that's just been kind of the hardest, more difficult aspect of REDCap is the hand entering the equations. And then also REDCap allows you to separate your data into arms. So I've created a provider arm and a survivor arm, and this allows you to designate instruments for survivors and providers for whichever type of data you're entering, and it will only pull up those necessary instruments for when you're entering data. And the qualitative data management has been managed through Excel. And it consists of 2 spreadsheets, one for user testing round 1, one for user testing round 2. 9 workbooks in the spreadsheets. They correspond to the menu subheadings on the Explorer. And then those are then broken down into the headings, menu subheadings. I'll show you an example in just a second. And each cell contains, like I said, the comments, the thoughts, the concerns, the likes, the dislikes, the way they were using the tool, how they were navigating, that sort of thing. And then we've just kind of applied this schema here. Red, negative comments, pink, positive, blue, wording issues. You know, maybe there's an apostrophe on it's that's not supposed to be there that people have brought up. Green, programming issues. And then the shadings are the changes that we made, changes we decided not to do, or changes that we're going to address later, see if other people have problems with whatever this person had a problem with. And this is my example. It's not the actual data, and it's greatly reduced, and I changed the wording around. But you can see it's broken down into menu subheading. This is corresponding to the introduction on the tool. And like comments that people made are lined up on the row. And if more than one person made a comment, for instance, regarding the navigation, do they use the menu or the arrows, it's tallied on the right-hand side. And so the user testing interviews, the common suggestions. I was able to sit in on a few of the user testing interviews and take notes, so that was really exciting. People would say, you know, there's too much information, there's too little information. I think part of the problem is that it's crammed into this hour and a half session, hour and a half session, and it is a lot to take in. So hopefully when it moves into something that people can actually use, they can use it at home, they can save their progress so that they can come back to it. It makes it a little bit more comfortable. Wording issues, maybe there wasn't a definition for ovarian suppression or something like that. People don't know what ovarian suppression is, so please include that. The tips, people have said that the tips are hard to see, or they don't notice them because the background is the same as the rest of the screen. And then the navigation arrows, which I've recently noticed, I think, went away. Decided to get rid of those because people had a lot of confusion about how to navigate. Do they use the menu? Do they use the arrows? What are the arrows for? That sort of thing. And then what surprised me the most and has been gotten rid of is the color purple. People had a huge issue with the color purple on the information heading, and the subheadings were all in the color purple, and they didn't like it. And I just never thought, sitting in the interviews, that the color palette would be a problem or that it would evoke emotion. And it certainly did. Some people wanted to see more tropical colors or neon colors, or some people liked pastels. They were very calming and soothing, and so that was just the most surprising thing. And then, yeah, I have the little kitty cat with so much purple. But that's all. Thank you for your time. And that article was Ulcerats, a generic tool for development of decision aids. Yes?
Thank you. I'm really intrigued by REDCap. Is your feeling if somebody's going to do a survey, they shouldn't fall back to SurveyMonkey or something like this? Because this seems much more suited to research. It looks great.
Yeah, I never knew about REDCap before I was said, oh, how about you go sit on this REDCap building session and build our database? And I was like, okay, what the heck is REDCap? I've never built a survey in SurveyMonkey, so I don't know if it's easier. For me, it certainly seemed really easy because you just go and you enter in your field, you put your options, and then you save it, and the field's there. So I don't know what the process is for SurveyMonkey, but it was certainly very easy, very user-friendly.
Is it free to use?
Yes. Are you obviously an OHSU student? There you go. Every Thursday they have drop-in sessions, and I believe they changed their training to every first and third Thursday of the month.
Actually, I can weigh in on the main issue, the main feature of REDCap is it's designed for collection of sensitive patient data. Probably, I've not used it much. It's probably not as easy to use or as flexible as SurveyMonkey, although it is pretty flexible and usable. But the key thing is that the data is stored in a secure way so that if there's human subjects data that you need to protect, REDCap will protect it and not just send it into spreadsheets that you just email places and lose on your hard disk and stuff like that. So that's one of the main functions of REDCap.
Yeah, and I should have mentioned that when building your instruments or putting in the fields for like the demographics, it says there's a clear question: is this an identifying field? Will this identify the patient or the subject? And then you click obviously yes or no, and then when you do export, it doesn't come up.
Just to add briefly to that, there is a version or a sister program, if you will, called REDCap Survey, and that's actually more parallel to the SurveyMonkey because that's meant to be an interface for the participant, whereas the REDCap version that you just saw is meant to be data capture on the back end. So that's for research assistant entering data, and then the REDCap survey is meant actually as the patient interface. So like what you saw, you would only see as the data enterer, but if you want an interface that patients can actually enter data directly, you can use REDCap survey, and obviously they talk to each other. Actually, they newly talk to each other much better, so you can integrate. And we've been using it for data management for almost everything. Because it's web-based and it's secure, it just alleviates a lot of the stress of the monkey, because we were using the monkey.
Karen?
Actually, Rebecca just answered it.
Oh,
I wanted to clarify to the group the process for getting data into the system, and you did it.
Yes, I believe in July. They used to be different URLs that you had to go in to access, and now they're under the one oaktree.ohsu.edu/REDCap, both survey and the research, the data capture. Another question over here? Yeah.
You noticed that people were focusing on color and purple. And it seems like this is a potentially sensitive and emotional topic.
Yeah.
And I wonder whether you think maybe they were focusing on color to avoid talking about other things, or whether you were maybe missing some of their more personal reactions to the system.
I would say no, because providers actually were the ones that brought up the color purple, not the survivors. So I'd be inclined to disagree. And in fact, I believe that the color palette of the tool has been the biggest thorn in the side for the tool, because I think it's undergone 17 changes, and maybe some more. And I think, from what I understand, it's a difficult process to find a color palette that's going to support like all black font, or are the colors too dark? Do you have to change to white font? They wanted it to be consistent, so we'll see if it changes again, possibly. Yes.
So when you had the screen with the different qualities about oneself that you could choose, I was wondering what the implications of like the choices that you made are in the tool, and how you, as the designer or the person in the back end, decided how to make those associations between different qualities of a person and whatever other elements.
I don't know if I'm understanding your question.
So you, for example, had that a person could be outgoing, or I don't remember what the specific adjectives were.
Who you are.
Right.
Choose the 3 words that best describe you.
Right, yeah.
Okay.
So I was wondering sort of what the thinking behind that was, and how you made associations between those and other things.
I have no idea.
I can speak to that. All of the content of the tool was based on qualitative research study. So that was actually sort of the pre-phase 1. Long before Katrina came on our scene, we did a grounded theory qualitative research study. So the content, and actually a lot of the specific language, came from when patients talked about, I think of myself as someone who is ... Those are the things that turned up. And that's true of all the content in there.
Just a final comment, too. The other piece is that one of the underlying theories was reducing conflict. And so part of this exploration activity was to help the person recognize, I have some skills, I have some decision-making skills, I've made decisions before. Also to reduce conflict around who are the people that are part of this decision, because sometimes the mother may think differently than the provider. And so how does the person resolve this conflict? So part of the purpose of this tool was sort of exploration, preparing the person for making a decision, which is novel. I mean, and we believe this is the same sort of thing that's needed for adults, too.
Okay, while she's setting up, happy to introduce Kristen, who came to us from UC Davis. Actually, has really never been to Portland before. The mic is not on. I'm happy to introduce Kristen, who came to us from UC Davis. Actually, never been to Portland before. Who looked at usability of the tool that was developed through our ISIS grant.
Hi, I'm Kristen, and I worked on the usability of a care coordination web tool. Care Management Plus was designed with the mission to improve the quality of care for patients with complex illnesses and older patients using 2 different factors, care managers and information systems. Care managers are usually nurses that have extra training in the fundamentals of care management, as well as the management of complex illnesses. And so when a patient is going to be enrolled into Care Management Plus, the care manager first assesses the needs of the patient and the family. Then with the primary care physician, co-creates a care plan, and then is involved in the implementation of that care plan. And the care manager is an important contact person and guide for that patient through the implementation of their care plan. The other part of Care Management Plus is the information system. The original tool was the care management tracking tool, and had extra features to help care managers with some of their tasks. Unfortunately, it required some double entry between the EHR and the IT system, so that was frustrating and very inefficient. So a new system needed to be built. It was called the Integrated Care Coordination Information System, or ICIS. It was built based on customer input. Both clinicians and care managers were interviewed, and 523 voices were heard and used into the development of ICIS. ICIS is a web tool that brings in information from the EHR, and so that eliminated the problem with the original system of the double entry. Currently, there are 7 different facilities using this system with 90 users. There are about 38 different pages with over 70 functions for them to use. ICIS was built from funds for a study funded by the Agency for Healthcare Research and Quality. This study was looking at how care management can improve the care for patients with complex illnesses using measurements from an IT tool. So ICIS needed to be built with features for 2 arms of the study. The coordination of care arm had features required features in ICIS for care management activities, and so ICIS could measure and guide that arm through completing those activities. And then the quality arm is the control arm where clinics use ICIS pages for quality measures, and they use those pages for guides in completing their benchmarks. So for example, the care coordination arm uses some of these features. For example, the patient worksheet can be printed and facilitates the communication between the care manager and the patient about their care plan. There's also a goals page where the care manager can sit down with the patient and think of some goals that they want to accomplish. And from that same page, the care manager can schedule follow-up appointments, which leads us to the encounter tickler, which is the care manager to-do list or task list, and allows the care manager to see the different encounters and telephone and in-person contacts they need to make with that patient throughout their care plan. There's also a summary page which allows the care manager to review and look at how their care plan is proceeding. A couple pages for the quality arm include the clinic quality summary report, which allows the clinic to look at their patient population to see how they are doing in meeting the quality measure benchmarks. And there's also a quality measure page which allows the clinic to view which patients are not meeting those benchmarks, quality measures. So I looked at usability, and usability is a measure of the efficiency, effectiveness, and satisfaction of a user interface or tool. For example, the top is a good usability where a user runs a quality measure, notes a number of patients that need follow-ups, and from that same page can schedule new encounters. An example of bad usability would be that they run this page, they didn't know that there was that feature to schedule appointments, and so instead they write all the patients' names down on a notepad, perhaps exit ICIS and go into their EHR and find the patients and schedule appointments through the EHR. This would be bad usability because they had to leave the system. There's extra steps. It's not simple and efficient. In the past, ICIS did have some usability testing where users were instructed to complete certain tasks. But some of the users were required to do tasks that they don't normally perform day to day. So for my project, I did not instruct users to perform tasks. I examined the usability of ICIS using logs of real-time recordings of the user's navigation and actions within the system. So the logs were recorded when a user when a page was loaded in the system. So for example, this user is on a high-risk page, and they want to view this patient. They click that link, and that brings up the patient page. At this time, the log records the date, the time, what page was loaded, and some other information. I looked at 8 months of data from October 2010 to June 2011. Using these logs, I did some descriptive analysis. I calculated the duration of time spent on certain actions and used pivot tables to summarize data. I also did some network visualization using UCI Net and NetDraw programs, where I visualized the total number of times users performed pairs of actions. I also did some workflow mapping to help look at efficiency. So in this example, there is a user at the encounter tickler, and that they looked at it for 15 seconds before clicking a certain encounter, and they viewed that encounter for 2 minutes and 15 seconds before they ended on that patient's page. So I found that the most frequently visited pages included both care coordination and quality measure design pages. So that is good for the study because both of these kind of pages are being used and can be measured. One thing I found very interesting was about the time spent on certain pages. About 62% of the actions recorded in the system over those 8 months lasted less than 5 seconds. So I called this a click-through action. So in this example, the edit, encounter, and patient pages, out of the total actions that were recorded in the logs, over 50% were clicked through. And then the patient edit and diagnosis pages had almost 80% of their total actions as click-throughs. To try to make some sense of this, I used some visualization of the pairs of actions. So the thicker the line, there was a stronger or a more common interaction between those two actions. For the patient edit page, there were 4 different actions, and the strongest link was between the view patient and the update patient. So I looked at that, and the view patient edit is simply viewing the page, and then the update patient edit is when someone clicks a save button. So there was a strong link between viewing and saving on that page. I developed this, I thought of this possible workflow to explain the high number of click-throughs that were recorded in the logs. When a user needs to edit patient information, they need to go to the edit patient page, and then they edit that information and then click save. That save would then reload the edit patient page, and that would happen in less than 5 seconds, and so the computer would record that into the log as a click-through. And my theory for the higher number of click-throughs for that patient edit page is because after that reload, users immediately navigate to another page. So they saw that reloaded page because that was required, but then they immediately went to a different page, for example, a view patient page, which is why there was like twice as many or more click-throughs for the patient edit page. I also looked at the workflow of enrolling patients into Care Management Plus. For this user, they needed to enroll 50 different patients, so a big batch enrollment. In order to do this, they have to search the first patient, go to the edit page, change the status to Enrolled in Care Management Plus, and then exit that patient and start patient 2. This is very tedious and repetitive workflow, and this person was able to complete that in 50 minutes, so a minute per person, but it might be beneficial to look at an easier way for batch enrollment. So in conclusion, although we eliminated the double entry inefficiency from the old tool, there is still some inefficiency in this tool. Almost 2/3 of the logged actions in the system were click-throughs, and a lot of them were buttons and reloads. And so it might be beneficial to reduce some of those navigations by having, after a person saves, it automatically goes back to that View Patient page with a notification of it's been saved. So we don't have to reload the edited page. We reload, or we navigate to the original page. And then there also needs to be an improved method for adding patients into care management. Perhaps a batch enrollment page where a person can just click next to checkboxes next to patients' names, and I'll add them at once instead of viewing each page or each patient individually. So for future work, it would be good to determine user satisfaction with the tool. Since I looked mostly at efficiency, usability also is measured by user satisfaction. So it might be good to administer surveys to everyone or many of the users to ask them what they think of the tool, and maybe certain aspects of the tool, like the enrollment of care management patients, was that as tedious as they think, or maybe batch enrollments aren't that common. That would be interesting to know through a survey. It also would be a good idea to re-administer the task usability testing, perhaps around this patient, or like the click-through pages, so see where users go after they reloaded edit page, and see if they are concerned with that or something. And then I just got the information about the types of users and facilities in the logs, and so I can examine click-through rates and pages based on the type of user, so physician versus care manager. And then also, more importantly for the study, the difference in facilities, so the care coordination facilities versus the quality arm facilities, and see which pages if they use their arms pages or if they accidentally click to other pages, and just information about that. So I would like to thank Dr. David Dorr and the Care Management Plus team for guiding me through this project, and OHSU and NLM for giving me the opportunity for this internship. Questions? Yes.
Always count on me for a question.
Yep.
Were there any IRB issues with, did you have to consent each and every user because you were capturing log data? Or was there some sort of loophole there where you could just analyze the log data without the user being aware of it?
Well, the users were just numbers, and I don't know who they are, or I didn't before. And there's no patient information in the logs. It just says view patient or edit patient.
So are there no IRB considerations then on using system log data, or not that?
I can help out with this. The whole study is it has an IRB, and for people to get access to the system, there's like for the usability related, where we interviewed them, there's consents that are done at the beginning of the study related to this. For this, it's we have a big waiver because there's like 80,000 patients in the system, and so we covered. This is covered under the waiver because it's de-identified information that we're collecting as part of the study.
If you're going to do this in real life, before you implement the system, make sure you've got access.
Yeah.
But the click-through loops were really interesting, and they showed these sort of dominant paths. But were there any kind of significant, side loops next to the dominant click-throughs, or, like with the one that goes back to the patient edit screen? Were some people, going back to the edit screen and doing a little bit more edits or something, or would that never happen?
I think that a lot of Kristen's analysis, she looked at individual workflows for how many cases? I think you did about
like 15.
About 15.
It's kind of hard to look at work, like the overall workflow. I just had to pick and choose. I mean, I had 136,000 rows in Excel to look at, so I just picked some important user actions, and I would start from there and see where they led.
Right, so she only mapped a few at this point, and so we haven't really explored all of those side loops, as you mentioned.
You would miss it or not, you know.
Yeah.
Did you also get a chance to observe the system in action?
I do have some access to it, yes. I can click through things, yeah.
You also observed a care manager using
Oh,
it.
yes. I also observed a care manager. Although she didn't use ISIS that much that day because she had other things come up. But she did tell me that for the tickler list, she prints it out once a week. And then she does update encounters in the system. But as for the tickler list, she prints it out and then checks it off there. And then updates it about once a week.
Just out of curiosity, ISIS, is it just in like this geographic region, or how many people are using it? Did you say? And is it at various locations across the United States, or just here?
Not yet. It's new, and for this study, they're mostly in Oregon and a couple in California.